So thank you, Ken. So Ken is going to talk about HIV testing, what is new.
Thank you, Dr. Kumarasamy. And I think this is a really important talk because many of you, if you're in ART centers or in private practice, you're used to seeing people who are already diagnosed with HIV infection. But I would submit that one of the most important things you can do is, we say in the U.S., see one, do one, teach one. In other words, you are the best people to provide HIV care in the country. You know how beneficial it is for people. I think trying to talk to your other colleagues, general doctors, general nurses, and clinicians out in the community, how important it is to be testing, because the epidemic in India has many similarities to the epidemic in the US, which is that a substantial number of people now know that they're HIV infected, but there's still a very high rate of new infections a year. We heard today from Dr. Gangadkar over 80,000 new HIV infections a year in India, but the infections are not always obvious. People don't wear a sign saying key population on their head, and so the only way we really can control this epidemic, the first stage, is testing. And so what we talk about now is a status-neutral continuum. All of you are familiar with the cascade going in the direction of, for HIV-infected people, so that you want to diagnose people, link them to care, and ultimately get them virally suppressed. But there's another cascade now, which is for people who are at risk, to get them onto PrEP, and certainly to decrease people's risk-taking behavior. But to know which part of the cascade you go to, you have to test. But there are a lot of barriers to testing. Stigma is the biggest set of issues. Nobody likes to be told by a provider or by their friends, gee, you're at risk for HIV, which may be disclosing unacceptable behavior. But as clinicians, we can normalize the conversation. But this field of testing really is a very dynamic one. So the first part of testing is which tests to do. And this means a certain understanding about HIV infection. So we have to deal with the reality that there's part of the infection, a very important part of the infection, where no test right now we have is going to work. This is so-called eclipse period. So this is somebody has condomless sex, and the next day they're not going to be viremic, they're not going to have detectable virus. They may have virus in their submucosa. It may be working their way into their lymphatics. But no test is going to pick up HIV for the first few days after infection. So that's the reality. So we have to know when the risk occurred before we can determine when to test. Then we have this period where a person may be viremic, where they may have RNA, but they will not have made antibody yet. For a long time, we were sort of stuck with either testing for RNA or testing for antibody, and RNA would turn positive 10, 12, 14 days after the exposure, but more expensive tests that we wouldn't want to routinely do. So we had first generation, second generation, and third generation tests. The biggest advantage of the third generation tests were that they developed rapid test platforms that you could get a result right away. But the third generation tests are not necessarily that sensitive, so it would easily take 3 weeks before these tests would be positive, and you'd have this period where a person would be viremic, but they would be antibody negative by the third generation test. The advantage of the fourth generation test is it includes antigen as part of the platform, and people will have detectable antigen much sooner. A few days after you have RNA, you'll have sufficient amount of viral material that the antigen test will turn positive. So the preference in the US is to use fourth generation testing. Now there is a fourth generation rapid test. I have to be honest, the test is not particularly wonderful. So when our preference is when we do fourth generation testing is to do it as a blood test in the lab. But this creates some tensions because you like to do things that are quick and simple. But you don't have to have the perfect be the enemy of the good. In other words, you can do a less sensitive test initially as a conditional test, and you can still send a test as well. So there are different algorithms that people can use to, depending on the populations in which you're testing. But it's just very important to keep in mind the distinctions between the different tests that we do when we talk about HIV testing. It helps us counsel people who are high risk about how often they may want to come back for testing. So this is the current algorithm in the United States, and I know that it's somewhat different here in India, but the preferred public health algorithm is laboratory-based testing. Doesn't mean that we don't want people to do rapid self-testing, but certainly ultimately we like fourth generation tests because it has the antigen and antibody combo. There are a variety of platforms. And one advantage about using some of these newer large machines is that they have fairly rapid turnaround. So you can actually, if you're a busy clinical center in many parts of the US, you can still give somebody a test result with a fourth generation test within 24 hours. It may not be while they're standing with you in the clinic, but you can definitely get it turned around fairly quickly. And then negative is negative, so that's useful. And then we don't use Western blots anymore as a preferred test in the United States. We use a differentiation assay then if you have a positive signal here. And these tests, the current fourth gen tests will pick up HIV-1 or HIV-2. Fortunately, HIV-2 is quite uncommon in the United States. But you do the differentiation here, and then you're detecting antibody. It tells you the person's infected. If it's indeterminate, then we would do a NATS test, because this might be somebody who is antigenemic, but doesn't have antibody yet, has acute infection, and we use that for further distinction. But again, I'm not showing this as the right algorithm as much as to say this is an algorithm that's evolved in our setting. But this algorithm doesn't mean that we don't promote rapid testing in some settings. If you have community workers going out to a party, to a club, and people who have not been recently tested, you want to offer the test, certainly that's good, but it's just important that those healthcare workers are educated about saying to people, this may not pick up an infection if you've been sexually active in the last 3 weeks, in the last 4 weeks. So that's the important part of the counseling when you use a less sensitive test. It's not that one test is perfect, because certainly for people who've never been tested, if they have never been tested and they are engaging in risky behavior, they may have long-established infection, in which case a third-generation test will work perfectly well. So it's knowing the context of the testing that's important. So the frequency of testing is the other issue. When we're talking about high-risk populations, individuals may be negative today, but they may become infected a few weeks later. So we don't want to have people think that I'm tested negative and that's the end of the story if they continue to engage in risk. So this was work from colleagues at Emory University, and they looked at the estimated incidence of the number of infections one might expect to see over a 3-year time horizon. And then they looked at different algorithms of what would happen. They made some assumptions about behaviors of people tested only every 3 years. And they said things would be a lot worse if, compared to the average rate of testing that we see in the US for men who have sex with men. 3-year testing, you'd get higher rates of infection. What would be the sweet spot? So it's not much better than the baseline scenario if you test once a year. If you test once every 6 months, it's a little better, but it's a lot better if you test every 90 days. You don't get much of improvement if you test weekly. So again, this is a model, but this kind of modeling is why the CDC suggests that for sexually active high-risk populations, quarterly testing is useful. Never testers. This is another issue in the US. Here we have had an epidemic that's more than 30 years in the making. We've had a quarter century of HIV testing, but in a recent internet study of men who have sex with men in the United States who recruited on social networking, sexual networking sites, 13% said they'd never been tested for HIV. So we still have a big challenge in resource-rich environments in terms of increasing testing. So what can we do to increase HIV testing? There are individual factors that we can do. There's some work that suggested that incentives may have a role for some populations, particularly economically disenfranchised individuals. And this gets into the whole discussion about do you incentivize good health behaviors? And certainly there are examples in different parts of the world where that does happen. And because we think that people who know that they're infected are more likely to get into care, and if they get into care and they're on treatment, they're less infectious, they're less likely to be engaging in transmitting behaviors. So you could argue that incentives may be an appropriate solution. I'm going to talk some about home testing, which I don't believe is yet approved in India. I'm looking at our moderators, but it's been approved for a number of years in the United States. There are social factors. There are studies that look at sexual and social network strategies of trying to influence key opinion leaders, of trying to work with networks to increase rates of testing. certainly peer support, so community education continues to be important, and social marketing. And then there's structural issues, and we have to face the fact that if people feel that the health environment is hostile, they're not going to go in for testing. So this means healthcare providers creating welcoming environments for sexual and gender minority populations so people feel comfortable testing, harm reduction for injecting drug users, we've heard before. So it's not just, gee, we have an ITCT or we have a testing facility or you can get tested in my office, but you have to feel comfortable because obviously with the stigma of HIV, a lot of people will avoid testing if they think the environment is not supportive, and non-clinical testing sites. And certainly there are examples here in India of NGOs that provide testing then linked to clinical sites, and that's another important model to think of. So in terms of home self-HIV testing, this is first approved in the US in July 2012. The test, you can get a result in 20 to 40 minutes. It's comparable to third generation testing. So again, the window can be 3 weeks to 3 months. And so it's, if you've been very recently sexually active, it's not the best test, but if you've never tested before and you're not going to go into a doctor's office, it's a great test to have. The test is very easy to perform. It allows people to collect the specimen, but there are other ways to test too. You can use the Oraquick test and get the result in your house, but there are also companies that actually have people send the result into them, and they can get the result in a plain unmarked box. You can also do dried blood spot collection, which is, you can even do more sensitive testing. You can do HIV RNA testing in research settings with dried blood spots as well. So there are a number of different ways of doing home testing to learn about HIV. But right now, the Oraquick test, the oral swab test, is the only. CLIA is a laboratory certification program in the US, so it's the only one that is CLIA waived, meaning that you could do it at home, meaning that insurance companies, for example, would pay for it in some cases. So the advantages are privacy, control of testing, availability. You can buy this test at the big chain pharmacies in the United States, rapid result, and ease of use. It's not a cheap test, though. It costs between $40 and $50, and not all insurers will cover it. It's not as sensitive as the blood testing. It's a single use. It's not something you might want to leave lying around your house if you live with your family. And then people have been concerned about linkage and about lack of counseling. Now, the company that makes it does have an 800 line, so people can call if they have questions, and people can get linked to local resources. There was a lot of concern in the beginning. What if somebody got a positive test? Would they commit suicide? There were lots of studies over the years that showed that that's not the case, that people who are spending this kind of money to get a test have an intentional reason why they want to know the results. So the social harms are not the issue, but again, certainly doesn't mean that everybody links to care effectively who has a positive result. I was involved in a study with my colleague Clay Merchant where we did an online survey of 425 young men who have sex with men from around the United States. They were recruited online and they were randomized. They agreed to be in a trial to either do home self-testing to get the result at home, to do home self-collection where they would send the specimen into the laboratory and then get the results subsequently, or to get tested, to get a coupon to get a free test at a medical or community-based organization setting. And what we basically found was that self-testing and the medical CBO testing was higher than self-collection. So the idea that you get the box at home and you swab yourself and you send it and then you wait for the lab, that was the least preferable means. And that actually about 2/3 of the people who got self-tests completed the test, and it took them about 14 days to complete between the time of getting this, the box and actually doing the testing. So people don't necessarily test right away. But the time to completion was longer for self-collection, sending it to a third party or going into a clinic. And the prevalence in terms of the number of people completing the test for self-collection was significantly lower for self-collection compared to home self-testing. There are tools that have been developed over the last few years. I talked earlier about PrEP with apps. There's also an app that our colleague Patrick Sullivan at Emory's developed called HealthMinder that walks people through stages of what you need to do for home self-testing. His group is now piloting with us self-collection that includes STD swabbing. So people get a box through Amazon, and it contains a DVD that tells people about how to swab the oropharynx, the rectum, get a urine specimen, and to collect blood for syphilis testing. And now with PrEP monitoring, we'll be collecting blood for tenofovir levels and creatinine as well, and trying to pilot that and see whether that's another way to get more consumer uptake of services around PrEP, because PrEP, we want people to be testing on a quarterly basis, but some people may find going into clinic problematic if they live in a more rural area, or if they have concerns about the clinic setting. So this whole idea of dissemination of home HIV testing is more than just HIV in the future. It may be the ability to do more self-monitoring at home. So home self-testing could address several concerns. The stigma, the access issues, privacy. If people live in small communities or urban areas where the community health center that they might go to, they may be afraid of running into a relative, a friend. This may address some of those concerns. Right now we're in the phase of so-called the early adopters. So this curve is called the diffusion of innovation. So in the beginning, this 2.5% are sort of the innovators. It takes time till the majority starts using a technology. So we're really in this early phase, innovators and early adopters, where it is being done, but it's not being the most common way. But we don't consider it the end-all and be-all, but it's another modality for testing. And the question is, we need to see who sees this as an advantage, because obviously one advantage of going into the clinic is you can have other healthcare needs addressed. And just like people are talking about differentiated care for HIV, where some people who are stable and highly adherent may benefit from just seeing a nurse periodically, other people need more services, wraparound services to address their concerns. Similarly, for testing and for prevention, we should think about different ways of providing care, different kinds of stratification of services as well. Another approach is that you're here on a Saturday because you are HIV specialists, you care about HIV, but there's this concept called public health detailing. And public health detailing is, how do you get generalists to think something is an important issue? So there actually was an interesting study that trained public health professionals to visit other providers. And the reason we call it detailing is that we have representatives here from pharma. In the US, we call it detailing when somebody from a pharmaceutical company comes to a busy clinic and says, I'll buy you lunch so you can hear about our new drugs. So public health detailing now is a concept of saying, buy lunch, but instead it's for a nonprofit trying to tell somebody about something they should be doing in clinical practice. And there's actually a whole center at Harvard that focuses on how do we do better public health detailing to train busy primary providers. You can imagine somebody who's been out of medical school for 20 years, new innovations in HIV testing may not be the biggest thing that they're thinking about, but they should be able to think about HIV testing, so bringing the message to them. So this was training these health professionals in Baltimore, and they got educational materials and resources at 85 clinics, and basically what they found was that after the detailing, the majority of people felt that they were highly motivated to routinely screen their patients for HIV. So again, this is self-report, but it does suggest that these kind of visits, this kind of on-site education can help influence professional behavior. Another approach, there's a whole concept in the US about health navigators. In other words, training people to help link people to care. So the rapid testing algorithm idea was test people and get them linked with somebody, have them meet somebody who they develop a relationship with who will follow them whatever the test result is. So they said that the norm should be, standard of care would be somebody going to medical clinic and having the test done in a laboratory and it taking several days. So what happens if you modify that algorithm? So one permutation would be have somebody come to a medical setting, but do a rapid test, but tell them that the rapid test is not definitive, and then have to follow it up with a Western blot. And then of the positive people in that case, the odds ratio was below 1, meaning that these individuals were less likely to link to care if they had to wait to hear about the Western blot. On the other hand, if you got tested in the clinic and you met this health navigator, even if you had to wait to get your definitive test result back, because you already had the relationship with the navigator, they had your cell phone number, you were much more likely subsequently to link to care. If you tested out in the community, you worked with a CBO, and you sent the blood to a lab, it wasn't statistically significantly different. But again, this delay, doing a rapid test and then a Western blot with no linkage, you were less likely to ultimately link to care. And if you did the facilitation in the community, it wasn't quite as good as doing the facilitation. It wasn't quite as good as doing the clinical tests with this navigator. But the data suggests that this navigation can be an important part of the puzzle, particularly if you're using third-generation tests and saying to somebody, we might still send your blood for a Western blot, and if it's positive, we'll have to come back and contact you. Another advantage about this idea of linking people at the time that they get tested, and obviously it takes resources to have these navigators, but the idea is that it's called status-neutral linkage. And this is a new concept in the US that people are talking about when you're interviewing high-risk people. Status-neutral means that because we now have really excellent treatment, so if you test positive, we can say we're going to get you on treatment, and that's a really good thing. If you test negative and you're high risk, we can link you to PrEP is the idea. So that's the idea of status neutral, that either way you're going to need to get linked to a program. So you might as well start meeting with a navigator, a peer counselor, sooner than later. Some of the questions that people have talked about are what are these linkage barriers and facilitators? So the barriers to this kind of work is that some of the clients have lots of needs, and the navigators may not be able to deal with everything. If somebody has a serious substance use problem, they are depressed, these are not psychotherapists, and we can't afford to necessarily link everybody to a psychotherapist right away every time somebody comes in for counseling and testing. So that's a challenge. There may be communication issues, staffing, and developing partnerships. But there are examples in the U.S. of CBOs, community-based organizations, and medical groups working together to develop effective partnerships. And certainly, if there are two agencies, one more medical, one more community-based, that are in the same community, these can create strong partnerships. So it's something to think about. It also allows for titration, a flexible model, and there are definitely examples of great success with these mixed models of doing the testing in a clinical facility but having the navigator available. One study that we were involved in was through the Adolescent Trials Network. This was a study conducted in multiple sites taking care of high-risk youth across the U.S. These were young people aged 12 to 24 years of age. And the sites were provided with an outreach worker, and then it was a randomized trial to see how effective was the outreach worker when you did testing. So we had a bunch of different metrics about whether people were referred to care, whether they linked to care, did they make an appointment for care after they were diagnosed with HIV within 6 weeks after the referral. Did they follow up with at least 1 week, one visit within 16 weeks of linkage? And were they retained? Did they have another visit within a year of engagement? And then were they virologically suppressed? So this is, the print here is very small, but the take-home was that there were 3 models that were tested. So model A was real-time data. So you'd share data with the health department, and there'd be a direct outreach worker working with the client. Model B was real-time data without the direct outreach worker with the client. And Model C was aggregate data sharing from the health department with direct outreach from the client. And and the take-home was, let's go back. Sorry. So the take-home here was that it was much better to have the direct outreach worker in contact with the real-time data is really the important thing. Direct outreach worker was really a big part of the equation. Something else that's coming down the pike in terms of testing is the Centers for Disease Control is trying to make it cheaper to do more molecular typing. And so they're trying in real time to give state health departments information about clusters and networks as people get tested. And again, this is something that I know that Dr. Solomon here has been piloting some of this work among some of the networks of high-risk people. So this again can inform people where the epidemic is going. This is not for routine clinical care, but it is something coming down the pike as we think about HIV testing. San Francisco has developed a zero San Francisco growth model. So in other words, they have a plan to say, how do they have zero new infections? A big part of that is focusing on HIV diagnosis, disclosure, referral, and scheduling. So what they have is something called the FAST team. So that means that if somebody is tested anywhere in the city, there is the ability to call a page number very quickly and to get somebody to come see them right away, to basically walk that person over to the clinic, whether they're tested in a CBO or a private office, to offer people same-day ART. It allows for flexible scheduling. They have standing orders for the antiretroviral regimen. So they'll send off a viral load, they'll send off a genotype on the assumption that the test will be positive, but they want to get people offered treatment right away to say, you have a treatable disease and we want to get you going. So it's a real rapid linkage of the testing to the treatment management. And their data is very impressive. So they said, back in the day when they were using CD4 guided treatment, it would take several hundred days before the majority of people were virologically suppressed. Between 2010 and 2013, when they said test everybody and get them on treatment whenever you can get them on treatment, the time to virologic suppression was 132 days. With this new rapid program that they have, the time to virologic suppression is 56 days. So again, if we're thinking about community viral load and trying to have optimal community suppression, these kind of approaches of linking the testing with particular staff that can help link people to care right away become very important, very engaging. And in this day and age, it's not just when you test positive and linked to care, it's also linkage to PrEP. So Charlene Flash, who was a former fellow with us in Boston, who's now in Houston at Baylor University, did a project looking at patients presenting for point-of-care rapid testing, and they got linked to prevention and care. And of 300 people that they thought might be at risk for HIV, they got 21% linked to PrEP right away. And they found that people who linked to PrEP were more likely to be women. And in the US, we have relatively fewer women on PrEP in proportion to the epidemic. So this seemed to be very effective for urban women in inner city Houston, also men who have sex with men. Many of the individuals already were interested in PrEP, so it was an easier sell, but also people who are in serodiscordant relationships, it was helpful. So this idea, again, of having the caseworker, the peer navigator available to link people right away works for both prevention and for treatment. So in summary, HIV testing is the entry into prevention and care continuum. Home self-testing has potential increased testing among priority populations, and the question is whether this is a technology that makes sense for some people in India. Obviously, a public health approach is not a cheap test, so it may not make sense more broadly, but certainly there are populations that can afford tests like this, and certainly with the innovation of Indian biotech industry, certainly home self-testing should be a very easy technology to make available. These rapid HIV testing algorithms with linkage, and that's the key, linkage navigation, can reduce linkage time and improve virologic suppression. That's what we've learned from the San Francisco experience. But we obviously know that San Francisco is not generalizable to the rest of the world, so we have to see how it works in other settings, how we can expand on the testing to link people, to get them to care, and particularly for those who are infected, to get them to the point of being virologically suppressed as quickly as possible. So this is another way of looking at the algorithm about you test positive, you get linked, you have to deal with issues like retention, you want to treat STIs and deal with behavioral issues. You simply want to treat STIs and behavioral issues for HIV uninfected people, but you want to think about things like PrEP, and if the exposure was very recent, potentially post-exposure prophylaxis. And behavioral issues, harm reduction is also part of the package as well. And clearly, these things need to be thought of in the larger social context under which risk might be going on. If we get this all right, we can decrease HIV incidence. So I just want to thank some of my colleagues who've influenced some of my thinking and provided some of the slides. And thank you for your attention.